Hi, guys. Welcome to A Little Help for Our Friends, a podcast for people with loved ones struggling with mental health. Hey, little helpers. It's Dr. Kibbe here. Before we dive into this episode, I wanted to tell you how I could help you navigate the mental health or addiction struggles of the people you love. Coolamine is the online coaching platform and community that I built to support you in the moment when you need it the most, like having hard conversations, asserting your needs, or setting boundaries. Even if you're just curious and want to chat about it, book a free call with me by going to the link in the show notes or going to coolamine.com, KULAMIND.com, and click Get Started. Thank you and enjoy the show. Welcome back, little helpers. We have a really cool guest today. His name is Dr. Geoffrey Grammer. MD, is a psychiatrist and a pioneering trailblazer in mental health care.
So I think it's important that your listeners understand that what we now know is that 1/3 of patients will not get adequate relief from medications alone, no matter how many medications you try, no matter what the combination is. And it is not their fault. They're not broken. They're not doing something wrong. This is the limits of medications. And for 70 years, medications worked on one of three neurotransmitters within the brain: serotonin, dopamine, and norepinephrine. But if your depression isn't tied to one of those three neurotransmitters, it's not going to respond to the therapy. So for decades, we had these non-responders, not because they were wrong or broken, but because the therapies were limited in what they could treat. So what's really nice now is that, after two medications, the likelihood of responding to a third or fourth starts to go down precipitously. But now we have new therapies and modalities that work substantially better in that population of folks, and more stuff is coming down the pipeline soon.
Whoa, okay. I didn't know that it was as high as 1/3 of patients don't respond to antidepressants. Can you say why? Do you know what depression doesn't actually respond to antidepressants? I don't actually know this.
Yeah, we actually don't quite have the capability yet in psychiatry to be able to diagnose why someone is depressed. We have some markers to suggest that. But the metaphor I would use is think about antibiotics. For years, we had these antidepressants that worked very specifically on those neurotransmitters. It would be like only having penicillin. But if you have an infection that is resistant to penicillin, it's not going to get better. Right. And this isn't my opinion. There was a large trial that was done called the STAR-D trial, which replicated real world antidepressant treatment. And that was actually sponsored by the NIH. And they showed that if you follow this very specific algorithm of escalating care with meds, you still leave 1/3, behind. And I think it's because depression is a heterogeneous disease, meaning it has multiple causes. Think of it like headache. You can have headache for a lot of reasons. Sometimes Tylenol works, sometimes Motrin works, but sometimes you have to take like sumatriptan, right? So depression is probably the same way, where it has multiple causes. And though we don't have the ability yet to say, here's why you have depression, therefore here's the modality, what we do have is, hey, we tried this, it didn't work, now let's try this.
That's so, no idea. What does treatment resistant depression look like? I mean, there's a ton of people who go, well, I'm going to consider SSRIs when I'm scared. I'm scared of getting antidepressants. What if it doesn't work for me? What does it look like when someone is treatment resistant?
Right. So by definition, treatment-resistant depression is a lack of response to at least two antidepressant trials. Now, to put this in perspective, the patients that I see in my practice have been on an average of 8 medications. So they blow through that definition. And I think it's important to recognize like what that does to somebody, right? Because, a lot of them drop out of care altogether. They're like, I'm not going to go see a psychiatrist anymore because they keep putting me on stuff and I get all the side effects and none of the benefit, and this isn't helping me. I see a lot of people internalize, shame inappropriately, where they assume like I'm doing something wrong. I'm not thinking about the world right. I'm not exercising enough. I'm not sleeping well enough. And that's not it. Right. And so, unfortunately for a lot of people, and I think we haven't done a good job in psychiatry at really educating people on this, but they personalize that lack of response. And that causes them to fall out of care and to further, lean into this idea of self-responsibility for their lack of response. And that's not the case. right? So part of our goal is not only to have people currently in psychiatric care come see us for things like NeuroStar TMS therapy, but we actually need to reach out to those who are in the community that aren't in care at all and let them know that something fundamentally different is finally out there.
So interesting. What about ECT or any of those, before we get into the cool interventions, what about, psychotherapy? What about ECT? I mean, I think the question that pops in my mind is there's some people who have such chronic depression that they don't know what getting better looks like. They might feel a little bit better, or they just might have that more negative outlook. Like what what should they expect from a treatment, and what about those other ones that we have? Like,
Yeah, so for years, ECT was the sort of next step after not responding to medications and therapy. And a lot of people had concerns about that. Some of it was stigma associated with the idea of ECT. The way we did it way, way back in the day led to a lot of memory problems. It's a lot better technology now, but it still is labor intensive, and about 70% of patients will develop temporary memory issues with that. So it's not an appealing option for some people, particularly if they're currently working, if they have childcare duties, if they can't take time off. That just isn't an option. For some people, it's life-saving, no doubt about it, and it should still be out there as an option for folks. But what about, the kind of walking wounded is what we used to call this in the military. Those who are going to work or going to school, they're kind of doing their stuff, but they're still suffering. It's not reached the level where it's life-threatening, but it is impacting their overall sense of well-being. And so something less invasive than ECT was definitely needed. NeuroStar TMS was one of those things that filled in that gap. So, and I forgot the second part to your question, but one was the ECT part, and the second part was.
I think it was just kind of like I was thinking about what people can expect from treatment.
Oh, that's it. Yeah.
I think that's the thing, because like some people will take antidepressants or they'll get therapy, and some things might improve, but some aren't. And sometimes it's our job as psychologists to try to explain what getting better looks like. But I think when we're talking about like treatment resistant depression or effective treatment, what does that look like with someone with like chronic serious depression?
Yeah, it's interesting because I think there's two parts to this. One is therapy and where does it fit within this, and the other is, what can people expect? And to your point, we certainly have seen this where someone has been depressed for so long that when they start to feel better, it can feel foreign. And it can lead to issues of who am I now that I'm not depressed? On a very practical level, if every weekend you spend it in bed sort of staring at the ceiling and all of a sudden you're feeling better and you're like, well, what do I do? And you don't have the repertoire of sort of options that you've just practiced for years and years, and suddenly you have to create that. I often tell people that one of the best times to do therapy is when you're feeling better. Because even though these meds can help with, some of the physical symptoms of depression, sleep, and so forth, sometimes patterns of thinking and behavior can persist after the depressive episode is resolved. And that's where therapy can be absolutely critical, right? And so I would encourage people that, if you're going through this and you're starting to feel better and you're like, man, I don't feel the way I'm used to feeling for the last 8, 10, 12 years, that's very normal, but you're going to establish a new normal that feels a whole lot better and it's going to allow you to be a lot more functional. And during that time to ease into that new kind of mindset, I highly encourage my patients to engage in therapy if they're not already.
Yeah, that's really beautifully said and beautifully describes why we say that medication plus psychotherapy or any other kind of behavioral intervention is good, because they're like, oh, I'm on the meds now. Isn't that enough? And, I've always thought about it as like the meds can be like gas on a pedal, but it's like psychotherapy helps you know where to drive. So it's like you might have the energy, you might have more flexibility and engagement, but it's like what you do with that then, like where you're going to put your attention, where you're going to put your thoughts and energy and things like that. So I really like the way you described it.
Yeah, absolutely. We always think in medicine of everything at risk and benefit, right? And the risks of therapy are exceedingly small, right?
Yeah.
But the
Yeah.
potential benefit is huge. And
Hmm.
so it's one of those things where, I think patients should really try to embrace and find a good therapist. I would put one thing out there. I tell people, finding a therapist is a little bit like a blind date. Like sometimes it's not a good match and it's no one's fault, right? It just, you meet with someone and you're like, we're not gelling. I don't feel like this person gets me. Don't turn off the idea of therapy just because you didn't meet with a therapist that you felt you resonated with. Meet with another. And a good therapist isn't going to be offended by that. I think we as providers, I have people that see me where I'm like, hey, do you feel like we can work together? And if they say no, I'm like, then let's get you someone who can. Like that, it's not personal for us. We get it. It's your journey. It's your life. You need to have the people on your team that you want.
Yeah, that's a good point. Should we do the same for medications? If the after two is considered treatment depression, treatment resistant, and I've like tried one, and then I've like someone tried Prozac, and then Lexapro, and then they're like, oh, now I don't really feel great. At what point should they go, uh-oh, this is a medication problem, and I
Yeah,
got to do something else?
there was a study done that took people who had not responded to two medications, and they were randomized to receive either a third or to get TMS therapy. And the group that did TMS therapy was significantly more likely to achieve either a remission, meaning asymptomatic, or a response, meaning a 50% decrease in symptoms, than the third medication group. So if you're playing the odds, you are more likely to respond to TMS therapy than you are a third medication trial. There's also a similar study looking at what we call augments, like probably the most common out there is aripiprazole, right? Otherwise known as Abilify. Same thing. If you're randomized to either, and again, this was a smaller study, but it was significant. If you're randomized to receive either TMS or aripiprazole, you're more likely to respond to TMS. And it gets back to that idea that for some patients, medications just aren't the treatment that's going to be effective for you. It's the medications that are failing the patient, not the other way around.
Wait, can you tell me a little bit more about what those medications do, like Abilify? I've always looked at those commercials and I'm like, if your antidepressant medication isn't working, put another one on. And I'm like, oh, like, how does that work? Does it work?
Yeah, I mean, treatment-resistant depression is really fascinating. And what happens out in the community is a little bit different than what the evidence shows. And that's not because doctors are doing stuff wrong. Like, we're trying to help people. And, research studies are always so narrow because you have to control the number of variables that it never extrapolates real easily to the real-world community, right? But with that being said, let's go over kind of what that journey's like. Most people will start an antidepressant, usually one of the SSRIs, because they're easy to take, they're low cost, and they have a favorable safety profile. And if that doesn't lead to an adequate response, then they'll often go to a different antidepressant in another class. So the SSRIs work by inhibiting the recycling of serotonin within nerves, so it increases serotonin used to transmit between two nerves to talk. Some of the other classes are like SNRIs, serotonin and norepinephrine reuptake inhibitors, or like bupropion is a dopamine norepinephrine reuptake inhibitor. So they work on some other neurotransmitters, but most of them have the same effect of increasing neurotransmitter response. Now, some of the newer agents do some fancy stuff, what we call postsynaptically on the receiving nerve, where it can try to fine-tune which receptors get stimulated and which don't. But no antidepressant on the market has consistently shown superiority over another. They all work about the same. So don't let any provider say, well, I like this because it works better. That literature doesn't exist, right? Like that's just not out there. In addition, there's no consistent convincing evidence that two antidepressants at once are better than one alone. There's a couple of studies that hint at it, but it is hardly compelling. And we see a lot of people come on two antidepressants. And I do that sometimes too. Like it's just part of what we do, but the evidence isn't really there. So then the idea came up with these augment strategies. And the medications that were originally developed for bipolar and schizophrenia at low dose were found in clinical trials to be significantly effective for people who aren't getting enough response from just an antidepressant alone. We're not entirely sure how they work. There's different theories. Part of it is it may increase sort of dopamine activity within the brain. Dopamine's sort of that pleasure reward response neurotransmitter. There's some fancier mechanisms that it probably aren't worth going into, but helping receptors do fancy things on the receiving nerve. But they were shown to be effective, but they have serious side effects. They can increase weight gain, they can cause sexual dysfunction, and they can cause a sense of restlessness, or what we call extrapyramidal symptoms, otherwise known as like Parkinson-like symptoms. And so that limits some of their utility for folks, and it causes concerns with long-term safety.
That's so interesting. Um, I just have so many questions. I feel like I'm getting like selfishly like a whole, overview of psychiatry, because it's something that we always work with as psychologists, but don't know the details about it. I have heard that some medications like Wellbutrin, some people are like, it saved my life. This is amazing. And some people have had a really, I'm talking about this anecdotally. I've seen some people and some patients who it's an astoundingly bad, not even just like it doesn't work, it doesn't treat their depression, but they get worse. Some people were aggressive, or um even thought of self-harm, or more impulsive than they were before. What have you seen that before? Or do you know anything about specifically Wellbutrin or a different class of medications?
Yeah, that's part of the reason why antidepressants require someone who's licensed to prescribe them be that portal of entry, right? Because any treatment we do in medicine can have side effects and risks, right? And what I will often tell patients is any medication can have any side effect in anyone. But let's take Wellbutrin, otherwise known as bupropion, for example. Wellbutrin looks molecularly somewhat similar to a stimulant, and it inhibits the reuptake of dopamine and norepinephrine, which are two activating neurotransmitters. People with a propensity towards anxiety or a history of trauma may get a worsening of symptoms if you're on Wellbutrin. One of the side effects of Wellbutrin is anxiety. Another side effect of Wellbutrin is those who are prone to have, say, perceptual disorders, what we would call hallucinations. Actually, hallucinations can be one of the side effects of Wellbutrin. It's rare. Most people do great, but some don't. So whenever I start a patient on a medication, I tell them, like, here's the things to watch out for that are common, but any med can have any side effect in anyone. And if it makes you sick, stop it and call me. We will often ask people to kind of tolerate a few days of nausea or maybe a little fatigue or headache. Usually that kind of stuff gets better. But man, if you take it and you start throwing up all over the place, like, talk to your provider. I wouldn't ask someone to be on a medication that does that. Same thing with weight gain. Like, that's another good example of, I don't think it's necessarily fair to tell a patient, I'm going to put you on this Lexapro, and they gain 40 pounds. And you're like, well, tough luck. That's not okay, especially when we have other treatment options. So sometimes it's a little bit of trial and error. We try to make educated guesses on what medicine might work best for someone based upon some of the mechanisms I've talked about here, but we don't always get that right. Everyone's physiology is unique and different. And so I think the biggest thing is, you need to feel like you can have a conversation with whomever is prescribing that for you. And if you have concerns about adverse effects, make sure you talk to them about it. And they'll either tell you, like, hey, this happens sometimes, you can get through it. But other times you're like, no, that's just the wrong medicine for you. Let's try something different. You're not taking the meds to make your provider feel better. You are paying your provider to give you advice on how to feel better. And if that isn't happening, they should be giving you different answers.
That's such an important message for people to hear, because I think a lot of people do get prescribed their psychiatric meds from general practitioners, or just people who go, okay, you're depressed, try Lexapro out, let me know how it goes. And some people might say, okay, I'm feeling better, but I'm struggling with weight gain, but so I love the message of talking to your provider with any concerns, and not just blaming yourself. So which
Yeah.
people with depression tend to do. So
Yeah, I'll tell you an anecdotal story, which when I was a junior attending, right, and unfortunately, I'm coming up on my 30-year medical school reunion. Like, how
my
crazy is
goodness,
that, right? But
congrats.
anyway, way back in the day, I remember I was seeing somebody who said, hey, I started him on fluoxetine or Prozac. And he came in and saw me. He's like, I'm doing okay, but I'm sweating on half the side of my face. And I thought, this can't be a side effect, right? So I do a literature search and find that indeed that has been reported with Prozac. And what it taught me was, no one is a textbook, no one is a clinical trial, everyone's an individual. Listen to your patients. If they say a medication is causing a side effect, it's causing a side effect. Take it seriously, right? So, just because you can't read it in the package insert doesn't mean it's not happening to you. If you're experiencing it, you should feel very open and comfortable talking to your provider about that.
It's good. It's good. What half of the face?
Well, it can be either half. It activates, we
Like
actually
up or
have,
down?
yeah, oh yeah, it's like midline over.
No,
Yeah,
that's wild.
it
That's
is
a
wild,
wild side
right?
effect. All right, let's say it's not working. Medications isn't working. I don't know if I could ever get better. What are the new frontiers? Tell me about TMS and like what is it for people who don't know what that
Yeah,
is?
so TMS, or transcranial magnetic stimulation therapy, okay, is it was actually FDA cleared back in 2008 for major depressive disorder, actually treatment-resistant depression. And it has since gotten actually FDA clearance for adolescent depression down to the age of 15, as well as obsessive compulsive disorder. And what we do is we take a powerful magnet, not like a refrigerator magnet, but like an MRI-ish magnet, much smaller though. And we place it on the scalp, and it pulses a magnetic field down onto the brain. And when it does that, it will gently stimulate the nerves in that area of the brain and exercise them, depending on the frequency we use. But usually, it will exercise them. And and what we know in depression is that there's an area of the brain that is often underactive. So instead of taking a medication, for example, that systemically goes throughout your body and is everywhere and bathes your whole brain in this stuff, with TMS, we can go in and directly start to activate an area of the brain that we know to be underactive in some patients with depression. And when we do that every day, just like going to the gym, that area gets stronger and it starts to pick up the activity on its own. And as it gets stronger, we see improvement in the depressive symptoms. So, I think the best medical metaphor for this is it is physical therapy for the brain. And it's not pseudoscience. Neurostar TMS therapy actually was studied in a sham controlled trial where half the patients got fake treatment and the other half got real treatment. And they didn't know what they were receiving. So they were blinded to that, right? So it's a good evidence trial, and it showed significant benefit. And there's been numerous trials since then confirming that benefit. And the FDA reviewed it and approved it. And what's nice about it is because it doesn't have those systemic side effects, you don't get sweating on half the side of your face or weight gain or sexual dysfunction or any of the issues that you have with medications. And what we have seen, the data that Neurostar has for adults is up to 83% of patients who didn't get better with medication therapy will have a significant improvement with Neurostar TMS therapy. And that is huge. Adolescents, it's 78% can have a significant improvement in symptoms. So when I say it's a paradigm changer, I mean it's a paradigm changer.
No, I mean, I the only the only exposure I've had to TMS is my colleague at Duke is running trials of TMS for emotion regulation and trying to stimulate the areas that are responsible for regulatory, changing the way they're thinking about their emotion. But I didn't realize it's this effective as a standalone treatment for depression. This is I wish I you know caught up on my neuroscience knowledge, but is it the same for everyone across different kinds of depression or different individuals? Is it usually the same brain areas that are underactive, or is it person specific where you have to put that magnet?
That's a good question. So, what I would say is there's no neurologic or psychiatric condition that you can think of that hasn't been studied with TMS at this point, right? So you'll find all kinds of stuff out there. But let's talk about what the FDA has kind of signed off on. So for depression, there's one sequence with the Neurostar TMS device that we use for treating depression that was cleared by the FDA, and that's treating over what we call the left dorsolateral prefrontal cortex. And for those on YouTube, if you're seeing my face, that's like here, okay, which is my left side. I'm not sure if the camera's going to reverse or not, right? Like right around here. But how we personalize it is tailored to the patient. So it's kind of cool because you think, well, how do you know where to go? Well, your body is mapped out over the motor cortex in a very predictable fashion. It's called the homunculus, right? And there's an area that controls like your leg, your hip, your arm, and where's my camera? Your thumb. And what we do is we take the magnet and we put it in near the area of the motor cortex and we start hunting around until we can make the thumb twitch. And that tells us where we are in the brain. And then we adjust the energy level to the minimum amount of energy needed to make the thumb twitch by directly stimulating those motor neurons within the brain. That tells us the intensity to give. And then we move forward 5.5 centimeters from that location, and that is the area that corresponds to the dorsolateral prefrontal cortex. So it's mapped to the individual, but the ultimate treatment sequence is standardized to that evidence-based strategy that was done in the original clinical trials.
That is so fascinating. That is so okay. What's what's the catch? I mean, that just sounds too good to be true. You just, you find it, you put the magnet, and then, I mean, what does the treatment look like? Like, how long does it take? Are
Yeah,
there
so people will sit
downsides?
back in essentially it looks like a dental chair, right? And they lean back, and we place the coil on the cap, and the magnet is in sort of a thing that looks like almost like a small kid's shoebox. It's about that size. It's five, for those that care, it's 10 centimeters across and about, I think, 15 lengthwise. And the provider will actually map out that location and then put it into treatment. And then most places will have a technician that administer the daily treatments. The treatments last depending on the sequence, but the current FDA sequence that we recommend is 18 minutes and 45 seconds. There's another FDA sequence that's a lot shorter, but I think most providers do that 18-minute and 45-second sequence. It might need to be customized. So if it's not that, don't come back and do like hate in the comments. Like there's a little bit of customization. And while you're getting treated, you're totally conscious, totally awake. You can surf your phone, you can watch TV, you can talk to somebody, like you're not out of it at all. And then when you're done, the chair, take the coil off the head, the chair comes up and you go out and you can hop in your car and drive and go to work and go to school and there's no downtime, right? So it's literally physical therapy for the brain, right? During the treatment, your scalp nerves are on the way to the brain, so they get stimulated too, and it can feel like tapping on the head. But for 95% of patients, that tapping is well within tolerable limits. And usually after about 3 days, most people get used to it. I'll tell you, some patients will even take a nap in the middle of it. They just kind of fall asleep because the chair is pretty comfortable. But it's actually, for what it sounds like, it is a remarkably sort of easy and safe treatment for people with depression. And you say, what's the catch? Even if you look at the most conservative efficacy data, I'm going to put a pin in it and say that probably the lower end is like 50%, and the average data is about 2/3 of patients get better, right? With the specific scales that I cited before being up to as much as 83%. All of that is tremendously huge for people that have not responded to multiple medications in the past. But the number one barrier is awareness.
Mm.
And that's what's so maddening, right? Depending on which data you look at, like right now, today in the United States, there's millions of people, up to, depending on the stats you look at, 4.7 million people with treatment-resistant depression. And an infinitesimally small number of those have ever even been offered NeuroStar TMS therapy. And that's one of the biggest tragedies of this. So my recommendation to your listeners is, like if you have been down that medication wheel and you want to try something different, like find a NeuroStar provider in your area. If you go to neurostar.com, there's a little physician finder. You type in your zip code, it'll show you the providers in the area, and go meet with them and see if you're a candidate. Worst case scenarios, let's say you're not for whatever reason, but man, it can be life altering for you. And the evidence shows that you're more likely to get better with that than the umpteenth medication trial.
Wow. I mean, case in point, I didn't realize that this was just available, that people can just go and get. I thought it was still being trialed, or it's still in very specialized clinics. But neuroscience, is that just one company? Do several companies make it? Like, can you just go to a clinic, or where can someone find TMS?
Yeah, I mean, there are multiple manufacturers, right? So I work for Neurostar. Obviously, I think our device is better, and I can certainly talk about why that is. But there are other manufacturers out there for sure. Quite. I mean, honestly, sometimes if I have someone that's moving to an area where there's not a Neurostar provider, I'll open up Google Maps and I'll say TMS near me, and it'll show all the providers in the area. And there are different providers out there. What I will tell you is, at Greenbrook Wellness Centers, we take, I'll use the air quotes, most insurance, which is my way of saying like nearly all. I'm sure there's like some small insurance company out there, but we will do all the lifting for you to try to, get your insurance to approve this so that your out-of-pocket expenses as low as possible. And we're very good at that, right? Usually most insurance at this point requires that you try one or two medications and you have a course of psychotherapy. And if those things are are completed, you may be a candidate. There are a few contraindications, right? If you have, essentially metal above the neckline, and by metal, I mean medical metal, not like dental work, jewelry, and stuff like that. But if you have like a ventricular peritoneal shunt or a cochlear implant, that could be a contraindication, right? There's a couple of medical things like that that a good TMS provider will go over with you. But the vast majority of people, it's like, yeah, I've been on more than two. I've been on 8, 10, 12, and I've been seeing a therapist for years and years and years. And you're like, hey, let's do this. Worst case scenario is it doesn't work, and then we move on to something else. And there are other things that we can do too.
The patients don't. Have you ever gotten it before? Have you ever
Well,
gotten
I've never been
TMS?
treated, but what I will tell you is every time we have a new provider or a new technician come on board, someone has to volunteer to sit in the chair and get tapped a little bit. So I have been tapped as sort of the volunteer while someone else is training.
And it actually works, or is it just like a placebo?
No, no, it's the real taps.
Do you notice any difference in the way you're thinking or,
Well,
like
like
functioning?
physical therapy or going to the gym, it takes a little bit of time to start to kick in. We usually tell people give it about 2 to 3 weeks to start to notice a benefit. So a single treatment won't do that much. There are some clinical trials showing some patients will score better within that first week, but it's kind of funny. And you've probably seen this in your own practice. When people start to get better, they're usually the last to know. They'll score better on the rating scales, their family and friends will notice, and then they start feeling better. So you can score a little bit better within the first week, but most patients will start to feel better around the third week. But during the treatment, yeah, it feels like someone's tapping you on the head. It's in some ways underwhelming, but it is a little bit of an odd sensation because, the magnetic field is just activating those sensory nerves in a way that normally they don't get activated. But it's hardly unpleasant, and again, most people tolerate it just fine.
It still seems too good to be true. What can people use it to enhance other areas of the brain without the depression? You know what I mean? Like, can I just be better at math? What about my memory? Can it
Right.
improve get me back to pre-babies memory stage?
Well, it's funny. As a representative of Neuronetics, I have to stick with the on-label stuff. But I'm not kidding when I say like this idea of it's a broader field called neuromodulation, and I think it's safe to say that there's a lot of interest in using this as a treatment for a variety of neurologic and psychiatric conditions. We've got the sort of two things right now. Actually, to be more specific, there's major depressive or treatment-resistant depression. Anxiety with depression actually received FDA clearance. The adolescent depression and obsessive compulsive disorder. And the way that we treat OCD is a little bit different than what we do with depression. It's a different location, and we do an exposure beforehand, and it accelerates the sort of response prevention that happens with the typical what we call ERP, exposure response
So
prevention.
cool.
Do I think those are the last indications to ever come forward in the technology? No. But if folks are interested, you look online, you'll find a lot of neat stuff out there. What I would caution some folks, though, I'm a firm believer in doing evidence-based care, right? I follow the literature closely. I don't want to experiment on patients per se, right? Make sure that if you see a provider that's promising you the moon, that you just confirm that what they're giving you is stuff that the FDA has said, like, yeah, this is a good thing. Because you can find some providers out there that will claim to be able to treat all kinds of conditions. And I think that's enthusiasm and altruism misplaced.
So what you're saying is I should find a sketchy, independent provider to bring back my my memory skills. Okay, great.
That's right.
Tell me why your TMS is different than, I mean, we're at the point where we didn't even know that we could go and find TMS, but why do you like your company better than the other
Yeah.
manufacturers out
So, and
there?
I've used, I mean, before I worked for Neuronetics, particularly when I was in the military, I've used a bunch of different devices by different manufacturers. And, I will say, I mean, they're all, those that are FDA cleared are all safe and they can be effective. But Neuronetics, who is the parent company for Neurostar TMS therapy, actually is one of the only companies that did a placebo or sham controlled trial to prove efficacy. The other manufacturers, with the exception of one, all said, well, we're like Neurostar as well, but they never did the study, right? And that's one of the tricky things in devices is you can show equivalency through calculations and some measurement of your magnetic fields, but they're not equivalent. And that's the problem because with Neurostar, we have what's called an iron core design. So the way the coil looks is it's a figure-8 copper wrapping, but only our device has an iron core in the center to focus the magnetic field. So you get the stimulation in the area that you want, but not in the areas you don't want. And no one else has that technology. In addition, we have what is called contact sensing. And we have two sensors on the coil, and they're very, very specialized so that if there's any issues with roll or pitch of the coil, where you would end up sending the magnetic field to a different area because you're not directly vectored down over the area you want to stimulate, this will tell you if you're off center. It makes it sure it's perfect. No one else has that technology, right? We also are the only company that has what's called a magnetic gantry arm. So like one of the devices I used to use had this like 20-pound coil that you twist a little knob and suddenly 20 pounds falls into your hand and you have to place it on the head and then twist the knob to tighten it up. Our gantry arm, there's a little button you press and it's this nice fluid, almost ballet-like thing where you can place it on the head, you let go of it and the magnetic locks fix, and it's just a lot easier to use. We also have proprietary software that allows us to track how patients are doing, allows providers to prescribe the treatment. You can follow their scores over time, and all that's cloud-based. So, we were the first to market, and we have proprietary technology to make sure that providers are doing it exactly the same way every time that no one else has. So that's why I think we're better than others. But to be clear, if your choice is no TMS or a non-Neurostar TMS therapy, you're better getting some TMS. But I would, if I were to get TMS therapy, I would get Neurostar TMS therapy. I mean, that's just being honest. I think it's the better device. Otherwise, I wouldn't work here. I could go work for someone else.
That's good to know. We'll definitely link your website and like a directory in the show notes just so people can find your TMS devices. Now I'm realizing that I was just in San Diego in a behavioral health tech conference, and there was a booth, like an exhibitor booth, with like TMS, and there was a person sitting there and in the middle of the exhibitor hall and getting TMS, and I was like, is this for real? Is this actually being like, what are they doing? This seems like a carnival trick, but I guess it's so available that it's legitimate that people are getting can get TMS.
Yeah, I think, if you think about it, psychiatry and psychology are one of the areas of medicine that are so embedded in our culture. Like there are some shows like ER and stuff like that, but there are very few shows where it's like, in the weeds of a cardiology practice. But even The Sopranos, had the lead actor going to therapy. So people know about this idea of mental health care, not just from engaging with that system, but because it's in all the stuff that we see with movies and TV and culture and dialogue and so forth. But that system moves a lot more slowly than medical innovation. And I think a lot of people are still conceptualizing mental health care based on the paradigms of care that are now 15 years old. And, again, if you don't want to believe anything I've said so far, please believe that there are options for people with treatment-resistant depression that don't involve just more of the same medications. And I prescribe medications and I think they're great and they're life-saving for a lot of people, but in those in whom it doesn't work, we now have actual evidence-based, FDA cleared, covered by insurance treatment options.
Really cool. Really cool. Tell me a little bit about, do you also do nasal ketamine or
Yeah, nasal
esketamine? Is that
esketamine,
different?
otherwise known as Spravato. So we offer that as well, and that is another great option. About equal efficacy to TMS therapy. What that is, so a lot of people are familiar with ketamine for all kinds of reasons. Nasal esketamine is sort of all that you want in the ketamine molecule, not what you don't want. It's a very customized molecule by Johnson and Johnson. And patients come into an authorized center. It's administered under an FDA program called the Risk Evaluation Mitigation Strategy, or REMS, to make sure everyone is safe. You get a very specific dose. There's only 2 doses. Both are extraordinarily safe. We hand you the nasal spray device. You squirt it into your nose. We do that either 2 or 3 times depending on your dose. It will cause some mild intoxication. We have to monitor you for 2 hours to let that kind of pass and check your blood pressure and stuff like that. And then afterwards, you have to get a ride home. We typically will do it twice a week for 4 weeks, once a week for 4 weeks, and then once every 1 to 2 weeks thereafter. But that works very differently than medications do, at least traditional antidepressants. It binds to a receptor in the brain called the NMDA receptor. And the reason that sounds new is because it is new, right? And it was shown in numerous clinical trials to be not only safe and effective in the short term, but actually the Johnson and Johnson has maintenance data going out to now 6 years showing ongoing safety. And for listeners that maybe got spooked by the Matthew Perry tragedy, this is not that. There's a big difference between getting street ketamine and injecting yourself in the rear end and going to a hot tub and getting a medically supervised treatment at a dose that is effective for depression. Ketamine is one of those medications where it's interesting. We have a few things in psychiatry where more is definitely not better, and ketamine-based therapy is one of those, where higher doses actually don't work for depression. You have to get this dose that's very, very specific, and with nasal esketamine, that dose has been confirmed.
That's fascinating because I've always wanted to learn more. I've heard more and more people going to, having very severe major depressive disorder, going to get to a clinic and getting more the IV kind of ketamine and then doing great. And I was skeptical. I was like, curmudgeon, like, oh, it's just too good to be true. No, it's really an effective treatment.
Yeah, IV ketamine is interesting. It's not FDA cleared, and we won't see it FDA cleared
Oh,
because it's a generic drug. No,
yeah.
but people use it, right? They absolutely do use it. I will say that dose is really key. So make sure if you are meeting someone for IV ketamine therapy that you ask what dose you're on and why. And they should give you a really good answer because that literature is pretty tight. Okay. But Spravato or nasal esketamine, okay, so sorry, going back to IV ketamine, one of the challenges is um, for ketamine to work, you have to kind of stay on it, like at least once every 1 to 2 weeks. And most IV ketamine clinics are cash only, and that can be cost prohibitive. Spravato is covered by most insurance, right?
Hmm.
So then you're just talking a copay for the treatment, and that makes it fiscally viable. I think with all these things like Neurostar TMS therapy and Spravato or nasal esketamine, I always see 3 barriers to care. Awareness, which we talked about, geographic proximity, so you got to find a clinic, and fiscal viability. And, we shouldn't have a system of healthcare where your pathway to feeling better is like doing essentially a mortgage payment per month to try to get treatment. So, before you go the IV ketamine route, my recommendation is see if there's a Spravato provider in your area and see about trying to get your insurance company to pay for your treatments so that you don't run into an issue where you have to decide between the cost and feeling better.
Yeah, that's a great point. Are there people who really shouldn't look into these? I mean, you mentioned contraindications, but are there types of patients or medical histories or types of even depression or mental health conditions that really should be careful with either type of treatment?
Yeah, I would say, unfortunately, bipolar depression is one of those things that neither nasal esketamine nor TMS has received FDA clearance or approval for. And just so folks know, even though bipolar depression has similar symptoms as major depressive disorder, we now know that those two conditions have to be treated differently. Right. If you treat bipolar depression like you treat major depressive disorder, there was another study called the STEP BD trial that showed that it didn't really work and actually may have made people a little bit worse. It precipitated mixed mood states and rapid cycling. So bipolar depression, unfortunately, those would not, for most patients, be something that your insurance company would cover. There are some providers that may try to work with you if you've exhausted other options. Spravato or nasal esketamine can't be used in women who are either pregnant or breastfeeding, and it shouldn't be used in those with a history of strokes, something called arteriovenous malformations, or with uncontrolled high blood pressure. Now, most providers will go through those things with you. Like, again, every medication, every treatment is going to have cautions and precautions and contraindications. They'll go through that with you. I will say TMS is a lot safer. There are some considerations we have in people with a history of seizures that may require some special precautions, or again, that metal above the neckline, or medical devices within 30 centimeters of the coil. But again, your providers will go over it. That's why you have to see your providers to make sure you can get it safely done.
Makes sense. Makes sense. That's so great.
Again, and this would be the one thing I would just encourage people to do. You don't have to suffer anymore. And it breaks my heart how many people I see. Like, I'll give you a couple of just anecdotes, right? Like, for people to know what this is like. I have a patient I'm treating right now with nasal esketamine. And, she had been depressed for decades and had the trail of life events that we often see in someone with chronic depression. And since she's been in treatment, she has been asymptomatic. And every week that I see her, she says, I wish I had known about this years ago. One of the first patients I ever treated with TMS therapy, a lot of people come in and say, I've been on every drug that's out there, and they haven't, but it feels like it. She really had. She was also doing cognitive behavioral therapy and supportive psychotherapy with a social worker. And she had been through years of psychoanalysis. So she had really
Done everything.
exhausted the continuum of care. And I remember it was one of the first patients I treated. I thought at the time, no way. This is, I was pessimistic. She completely remitted from her depressive symptoms in a way that she had never experienced before in her life. And to that psychotherapy thing we talked about before, she had this great metaphor. She said, it's like my pond has been drained. And now all those rocks that were covering issues I had to deal with, I can finally see and turn over. And she stayed in remission for 5 years. And she came back with a return of symptoms because she had a dear family member who had a terminal illness. And we treated her again. She went back into remission, and she came back and thanked us and said, because I wasn't depressed, I was there, to be available to my family and to help everyone through the grieving process. And I was able to be present. So, there is no depression that is too severe to explore these modalities. There is no case that is too hopeless to get this. The only way to know if it's going to work for you is if you access the treatment.
I'm totally speechless. That was a beautiful example that is so hopeful, because there's so many people who are just like, it just, therapy doesn't work for me. Medications don't work for me. I guess this is my personality. I guess life is hard, but it's so exciting to know that there are available, effective alternatives to what we all know. So thank you so much for this. Where can people find you, or where can people find Neuronetics, TMS, or the nasal esketamine?
Yeah, so if you go to neurostar.com, that can find you any TMS therapy provider in the country. And they will actually, there's a way that you can click on a little link to try to, get someplace that's close to you that you can actually search by insurance and so forth. It's really great. What I would also encourage people to do is if you Google Greenbrook Wellness Centers or greenbrooktms.com, um, you can find a Greenbrook Center, near where you live. And we pride ourselves on kind of doing the heavy lifting with insurance. That's kind of our claim to fame, because we feel like if you're coming in with depression, the last thing you should have to worry about is battling your insurance company to get approval. So we have an entire team that's dedicated to doing that. And we would love to be part of your journey towards recovery. We really would.
That's fantastic. I'll link all of that in the show notes. So if anyone's curious, you could look at the episode description. Thank you so much. This was such a fascinating conversation, and so I feel so energized and hopeful for all these different treatments. This is so great.
Well, thank you for the opportunity. I appreciate what you do and what your organization does. And, I think we're all in this battle together to help people feel better.
Oh, that's so great. Thank you. All right, listeners. Well, if you want to lift my treatment to resistant depression, leave a 5-star review, or share this with a friend, especially, and spread the word about TMS and nasal esketamine, the different ways that people could actually get treatment. So thank you so much, and we'll see you next week. By accessing this podcast, you acknowledge that the host of this podcast makes no warranty, guarantee, or representation as to the accuracy or sufficiency of information featured in this podcast. The information, opinions, and recommendations presented in this podcast are for general information purposes only, and any reliance on the information provided in this podcast is done at your own risk. This podcast and any and all content or services available on or through this podcast are provided for general, non-commercial, informational purposes only, and do not constitute the practice of any medical or any professional judgment, advice, diagnosis, or treatment, and should not be considered or used as a substitute for the independent professional judgment, advice, diagnosis, or treatment of a duly licensed and qualified healthcare provider. In case of a medical emergency, you should immediately call 911. The host does not endorse, approve, recommend, or certify any information, product, process, service, or organization presented or mentioned in this podcast. And information from this podcast should not be referenced in any way to imply such approval or endorsement. Thank you.